you.
Today. He's going to be speaking to you about so many important topics, health policy and becoming politically involved. Dr. Stephen Ferrara is the Executive Director of the Nurse Practitioner Association of New York, as well as being, I think, an associate
dean.
dean
Yep.
at Columbia School of Nursing. So we are very proud and honored to have Dr. Stephen Ferrara come. So let's all give him a nice hand.
Thank you. Thank you for having me, and thanks for listening about, well, I hope you'll listen, about the Nurse Practitioner Association. So everybody in here is either an NP student of some sort, right? Okay, good, so I'm in the right place. And as far as graduating goes, how close or how far are you from graduating? Okay, so we're close, right? So, all right, that's a good time. It's a good time to be a nurse practitioner or a soon-to-be nurse practitioner. Lots of opportunities, and I want this talk to be as interactive as possible, so please ask me questions if you have them, and hopefully we'll all learn something a little bit. So, as soon-to-be nurse practitioners, who regulates nurse practitioner practice in New York State? The Board of Nursing, good. So the Board of Nursing, that is correct. So each state is responsible for defining and regulating the practice of nurse practitioners. And AANP, is anybody a member of American Association of Nurse Practitioners, AANP, the National Association? I'm also involved with that association too. I'm the regional director of that, which is New Jersey, New York, and Puerto Rico. Don't ask me how that happened, but that's how it is. So we've designated 3 categories. Full practice authority, which is when no physician involvement is required for nurse practitioners. Collaborative status, there needs to be some relationship with a physician. And then there's supervisory status, which is where supervision of practice is required. Do you know where New York State falls in on that category? Collaborative. Yes, but we're sort of more collaborative to full than the other way around. And I'll talk about that a little bit. Does everybody plan on staying in New York following graduation? Are there any other states that you are looking to move to if not New York? Jersey? Oh, Georgia. Ooh, that's a hard state for nurse practitioners. We'll talk more about that. Ooh, sorry. Ooh. Ooh. So these are all Florida, South Carolina, Georgia. Connecticut's a good state. Maryland is a good state. PA is right now not such a good state. They're trying to move forward. Texas, ooh, sorry, Texas. So why do I say good, bad, or indifferent? Because each state has its own classification. And here's the challenge, right? Every nurse practitioner goes to an accredited school. We take the same certification exam, but what you can do as a nurse practitioner is dictated in the Nurse Practice Act of the state in which you are licensed in. And the reality is, each state is different. And that makes no sense. Why can you be in a state that's very free, such as Vermont for nurse practitioners, where you graduate, you open up your own practice, you don't need a physician to sign anything, versus Texas, where you're a nurse practitioner, not only do you need a written agreement with a physician, but a physician has to spend a certain amount of time physically at the same practice as you. That makes no sense. That makes no sense, and unfortunately, there's not a way to make all nurse practitioner licenses the same across the United States. It has to happen in each and every state. So this is a challenge for us. This is a challenge as NPs because, look, even as RNs, an RN is an RN. We could do the same thing pretty much across the United States. Same thing as a physician. Physician is a physician. Nurse practitioners, well, in this state I can sign a death certificate, in this state I can't. In this state, I can prescribe medical marijuana. In this state, I can't. It makes it very challenging. It makes it very, very challenging to our patients, when they're coming to you and saying, take care of me. I found you as a nurse practitioner. I want to see you. I want to get my care from you. But you say, well, I could do this, but I can't do that. So it makes no sense to me. I hope it doesn't make a lot of sense to you either. And by the end, we're all going to storm the castle and change things. So in New York State, can an NP own his or her own practice? Yes. So that is a resounding yes. And in New York, are you familiar with the Nurse Practitioner Modernization Act? Yes. Good. So this is a law that passed, became effective in 2015. And this said that if you're an experienced nurse practitioner, which is just under 3,600 hours of clinical practice, which is about 2 years full-time, no longer do you need a written agreement with a physician. You can practice and, you have to maintain a collaborative relationship, but you don't need their signature. But for NPs with less than 3,600 hours, you can still own your own practice, but you do need a written collaborative agreement, and you do need to have practice protocols and certain things that I hope you're all learning about, because you will be or are inexperienced nurse practitioners. So when you graduate, you'll have a written agreement with a physician in some way, shape, or form. So, inexperienced nurse practitioners, what happens to your practice if something happens to your collaborating physician, such as they move out of state, they retire, they lose their license, they die? What happens to your practice? Say again? You have to find another collaborating physician. Do you have a grace period? I heard yes. I heard no. 6 months? No grace period. Immediately. So, and this has happened. I use these as real-world examples. We've had NP practices in New York State. This is prior to the Modernization Act passing. These practices were primary care practices. They were busy. 2 nurse practitioner-owned practice. One day, their collaborating physician came to them and said, I have some news for you. I took a new job. And they were like, that's great. Good for you. Take a new job. They said, but as a result of my new employer, I can't collaborate with you anymore. They had patients on their schedule that, had they not had a backup collaborating physician, they would have not been able to see those patients that day. And what changed? What changed in that time period? Nothing. That NP skill, education, experience, that didn't change. But technically, they wouldn't have been able to see any patient, provide any patient care as an NP, if they didn't have a written collaborative agreement. So I hope, yes, question.
What is the criteria or the requirements for the collaborator physician?
So the question is, what's the requirement for a physician collaborator? So the physician collaborator has to be in the same specialty as a nurse practitioner. Now, here's a problem with that statement. Physician specialties and NP specialties are not the same. So if you're an FNP, you have to have, and you're seeing children, you either have to have a pediatrician, a family medicine physician, or a combination of an internist and a pediatrician if you're seeing pediatric patients. A lot of physicians specialize in cardiology. There is no cardiology nurse practitioner program that I'm aware of in the United States. You're an FNP or an adult gero NP, and you essentially learn on the job and get hired by a cardiologist and work as a cardiology NP. But there's no formal program to become a cardiology NP. And that goes to any specialty, orthopedics. New York designates 16 specialties for nurse practitioners. Among those 16 specialties, family, adult, gerontology, women's health, psych, and then we get into some of peds. We get into some of the really odd specialties. If you look on the State Education Department website, the Board of Nursing website, you'll see that there's a holistic nurse practitioner. I don't know what that is. But at some point in New York State, there was a program that you could go to and become a holistic nurse practitioner. But today, you know, you want to practice in a holistic way, more power to you, but you need to be educated either at a family, adult, gero, or women's health level in order to do that. So it gets very, very confusing. But so that's about a physician and who you can collaborate with. It's a good question. Is there incentive for the physician to collaborate with you? So it's a free market. So if a physician wants to charge you, they can and they will, and they have. So now, if you work at an institution, they're not going to charge you, right? If you work at a hospital, they're not going to charge you extra. But say you wanted to open up your own practice. Why would, you know, Dr. X say, yeah, I'll collaborate with you? Dr. X is going to say, you can pay me $1,000 a month, and I'll sign whatever you need me to sign. And that is what has happened. So there's a wide range of how much NPs have paid physicians, anywhere from $500 a month to $1,000 or more a month. And think about it. That money goes into the physician's pocket. It doesn't go into your pocket. It doesn't go into the healthcare system's pocket. It's going to them. It's because you need that in order to practice. So it's sort of they're holding us hostage, which is part of the reason why we were able to successfully get the Modernization Act passed, because we said, this is wrong. We are educated and board certified and licensed to not have this sort of supervisory model. So let us break free from this written agreement. And fortunately, the legislature agreed. So I'll talk more about that. Any other questions on collaborative agreements? Yes. Yep.
You don't have to sign off on any of your charting?
No. So after the 3,600 hours, you're free.
Totally free.
Totally free.
And one more thing, for women's health NP practice, for collaborator be a primary care?
So can women's health nurse practitioner have a primary care as a collaborator? Yes. I mean, if that primary care, assuming they did a residency that included OBGYN, which most do, then yes, the answer is yes.
Doesn't have to be an OBGYN.
Doesn't have to be an OBGYN, but that gets a little bit gray, right? So, you know, especially if you're doing procedures and, you know, getting involved in some complex stuff. Because at the end of the day, you want somebody who you can call and say, hey, I kind of got myself into a little pickle. I did this, and the patient hasn't responded. So you want to call somebody and have as your resource somebody who knows what they're doing.
Let's say you're hired in an office that is a primary care office.
Yep.
How does that work?
So if you're hired as a primary in a primary care office as a women's health NP,
But you're not doing like major GYN procedures, you're doing like basic
annual visits and yeah, PAPs. There's no problem with that. Now, I say that, right, but it depends if the office is part of like a hospital system, because we have credentialing departments that set their own rules. So there's what New York State law states, right, but then there's what the institution requires. And I know there are many institutions that say, no, if you are a women's health NP, you have to have an OBGYN. That's not the letter of the law, that's their internal policy. So if you're, when you're going out looking for jobs, and you know, find out who the office is actually owned by. Is it owned by the hospital system? Because if it is, you fall under the credentialing of the hospital. If it's a private office, then there's really no criteria at that point. And then you get into billing and insurance companies and getting impaneled by insurance companies, which you also have to check. It shouldn't be a problem. Again, if you're doing routine annual women's health, it shouldn't be a problem to bill out as such. But you definitely want to make sure. So it gets a little complicated. All right. Yes, question.
I know someone she worked on a neurosurgery floor. When she got her license to practice as an FNP,
Yep.
instead of practicing as an FNP, one of the doctors wanted to hire her at the hospital as
Uh-huh.
a neurosurgeon NP,
Uh-huh.
but her degree is in family nurse.
Right. So this happens a lot. So the comment is RN worked in neurosurgery, became an NP as an FNP. One of the neurosurgeons wanted to hire her as to work in neuro. Now, technically, that's okay. And I'm assuming that neurosurgeon is training that NP as to what they do. Is it okay? Yeah, it is okay. But that's where it gets gray. Because again, there's no formal training as an NP to be in neurosurgery. I mean, surgery is not an area that NPs are in anyway. People ask me all the time, well, I wanna do surgery with ortho. Well, then you become an RN first assist, and that has nothing to do with being an NP. And then you could be in the OR, you could do whatever, but it's separate than being an NP. So it gets a little bit, it raises lots of questions. Is it appropriate? It's appropriate depending on what they're doing, what their role is. Are they doing follow-ups? Are they doing refills? But you also want to find yourself in a position where you're actually utilizing your skills as an NP and not being a glorified RN. You're spending a lot of money and time to become an NP. You don't want to end up in a role that, basically anybody can do. So keep that in mind too, because that has a lot to do with your long-term success and you wanting, job satisfaction. If you're not happy, then, it's not gonna last, so. All right, any other questions? Yes?
If you're, let's say, for example, you're in specialty, like I'm a women's health.
Yep.
I'm in women's health, and let's say you're hired, one of us are hired into a primary care facility.
Yeah.
And so they see a variety of patients, not just women's health.
Mm-hmm.
And so I know that we're allowed to see men in regards to fertility.
Mm-hmm.
What's our are there any limitations to our scope of practice of seeing adults? Because we do family nurse practitioners.
Right.
One semester of OB and make practice OB.
Right.
So how does it work in reverse for us?
So it is more limiting as a women's health nurse practitioner. So you're not going to manage diabetes in your patient as a women's health nurse practitioner.
Well, if you saw a woman who had diabetes, you would manage it.
You would manage it. You would. So it gets also now managing it. Are you titrating meds? Are you newly diagnosing? There's a line and there's a standard of care, right?
We'll diagnose gestational diabetes,
Which is absolutely appropriate. But there is a line. There is a line crossing over into a type 2 diabetic because technically that falls more under a primary care. What do you say?
According to NPWH, you should be able to manage primary care. So you should be able to seek women for diabetes, and there are
Right.
lots of women's health, not here in New York where there are so many providers,
Right.
but in places like Kentucky
Yep.
where there's no one, yes, there is. So according to our school,
Yep.
yes, and that's why I tell them, according to NPWH, we're able to see men for reproductive and sexuality issues and things of that nature.
and nothing else.
Not necessarily, not for management of primary care issues.
Right. So what if so this is the question, you're saying not to be a glorified nurse in an office setting. However, let's say you're practicing as a women's health practitioner in a primary care setting, and then you are seeing, let's say, a man for fertility issues, and you do have your overseeing collaborative physician, and he also has, let's say, diabetes, right? And you're working together, and it sort of overlaps a lot, what you can do as an RN, and what you can't do as an MP, or what you could do, how do you know all these gray areas? And there's how, even if you're working in, let's say, just an OB/GYN office.
Yeah. Go for it.
I'll just say, being in an OB/GYN practice for 30 years, there's lots of times when patients come in and they, they'll tell you that they have run out of their medication for their hypertension or diabetes or behavioral health issues is a big thing, mostly, right? And so then you're in a quandary. Are you not going to refill their medications? Or you can then collaborate with their other healthcare providers. You're not going to just leave them hanging in the lurch. You know what I'm saying? But to manage it on a continuous, ongoing basis, I would say no.
No, you're not right. Okay.
But in that moment,
Yes. I mean, you're responsible, and this is where the onus is on you as a provider, unfortunately.
Document that they claim to refer for follow-up, like you're refilling your prescriptions, but you want them to refer for follow-up.
Right, right.
Or if you're working with a collaborating primary care physician, then you're referring to your primary care collaborator.
Absolutely. So, again, you want to make sure you're following the standard of care and you're not abandoning your patient unnecessarily. And the onus is on you as a licensed provider. So you want to make sure you're practicing within your scope of practice and allow. I'm trying to find it online. New York State has a section that kind of goes specialty by specialty and gives a very rough idea of the populations that you can serve based on your licensure. And of course, I can't find it as I'm trying to pull it up right now.
I'm going to add something to that. Just
Please do.
So that you have a few minutes to find it. So if a patient comes to you and she has chronic hypertension and for some reason you feel like it's out of the scope of your practice and you don't refill her medication, then she then leaves and has a stroke, hypothetically, is the onus then on you because you didn't refill her medication? Or should she, you could then say, well, I referred her back to her primary care provider. It's a sticky situation. So because then you don't want them to say, well, I came to and asked you to refill it and you didn't, and then this happened to me, so now you're responsible.
Right.
Do you see what I'm saying?
Yeah.
Because she could turn, maybe they can't get an appointment right away, or maybe, whatever. And so it's sort of a quandary no matter what area of medicine you practice.
So in that situation, say right now like an emergency, like 72-hour refill, would you get dinged for doing that if you were like a 72-hour refill?
And
of that
72 hours is not a lot. That's only 3 days.
I know, but I'm just saying, like,
I gave you a few weeks.
They'll go without.
Yeah, because have you ever tried to call where everyone's young in this room, so probably you don't have chronic illnesses and you probably don't have a primary care provider, but if you ever try and call one and get an appointment, you're not getting one tomorrow or the next day. So it's going to take you a while, so I would give them a good few weeks.
Okay.
I think if you go to your pharmacy, they're entitled to give you for 5 days.
I don't know about that. Go ahead.
I work with a physician, and what I see sometimes the patient will come, they are on the medication, she just said like 1 month supply until she sees her doctor. So
Yeah, you get them 1 month. Just like if they go to their primary care and they run out of birth control pills, well, they're going to refill it for 1 month. But a lot of times primary cares won't refill it because they feel like it's out of their scope. Yeah,
Or like, what if the patient tells you the wrong medication or the wrong dose, and you're
you can always call the pharmacy. And now everything is on the EMR. You can't even imagine everything.
no,
is
but
on the
you
EMR.
can look up another patient what they've been getting.
No, they have to, and no, wait, hold on. So on the EMR is their pharmacy. You can call and speak to the pharmacist. You can call and speak to
And also, don't get patients like to bait you into prescribing something that they think they might have been on, and at the end of the day, it's your signature, electronic signature, on that prescription. So it may be for convenience. Oh, can you just write me a so-and-so? Say, look, I can't. I need to verify it. It's my license. This is what New York State says for women's health. This is on the State Education Department website for women's health. Diagnoses, treats, and manages the care of women and female adolescents. Women's health NPs may provide primary care or acute care. They may address acute or chronic health problems or provide preventative or supportive care. Women's health NPs may also screen, diagnose, and treat sexually transmitted diseases in men and in male adolescents. So, right from New York State. Now, is that a little bit ambiguous? Yes, but it needs to be ambiguous because the what-if questions, we're never going to be able to have a statement that answers all the what-ifs. What you need to do is ensure that, again, if you're a women's health NP and all of a sudden you're diagnosing, a schizophrenic patient, that seems to me not appropriate. Are you going to refer them to mental health psychiatry? Absolutely. Could you get them started with some counseling? Yes. But know where, the limits are, and just be cognizant of what you're allowed to do or not do.
Right, so like,
Yeah.
Let's say you have a patient coming in with, and you take the blood pressure, have them come in the office.
Yep.
It's high.
Yep.
Have them rest. Continue again. It's high. You say, okay, come back in a few weeks. I'm gonna come back and let's say, next week for a recheck.
Right.
And if you're starting to think maybe they have chronic hypertension,
Mm-hmm.
and then it's high again. At that point, you'll say, okay, I'm gonna refer you to cardiologist, but you don't have to refer right away in the beginning if you're not like that.
No, no.
You might start to think that that's the diagnosis you're heading at, but
Right.
not necessarily are you diagnosing them with chronic hypertension.
Right. You're following a standard of care. You're not saying, oh, your blood pressure is high, let's throw you on a beta blocker. You know, you're following, some conservative management, making sure there it's not white coat hypertension or whatever, but that's totally appropriate. That's totally appropriate.
And let's say you have a male patient who you're coming in and you're doing, you're screening them for chlamydia,
Yes.
but then their blood pressure is high. Or then he starts discussing a different health issue. We did do a semester of primary care adult medicine. That's what I'm confused about.
In that instance, I would say you need to follow up with your primary care provider because that starts you down a road that gets way too gray. And especially according to this definition on the state education website, it specifically states screen diagnose sexually transmitted diseases in men and adolescents.
Right, so let's say he says to you, let's say I'm running out of my hypertension medication. Can you refill?
I'm sorry, I can't. I'm sorry, I can't. Right. Well, for that, again, that you're limited because, again, the population. Refer him to her. Right. So what New York State allows to see men sexually transmitted diseases treating men and adolescents. Anything beyond that is a hard stop. No. Now, different if it was a woman. If it was a woman, different story. But and does that make sense? No, not necessarily. But this is what you're licensed to do. This is how New York State sees you. So therefore, refer them out.
It really doesn't make sense because what pisses us off is that they do one semester of OB and practice OB, but we do one semester of primary care and they.
We could debate that all day, and that would be a problem.
Let's just put it like this. When you look at physicians, there are certain physicians, they have a specialty, but they want to manage everybody.
Right.
They're renal, they want to do diabetic,
Right,
they want to
right.
do this, that,
Yeah.
and the other, and it's not safe. So you have to look at it from that standpoint. If you're a woman's health, you want to keep it within your scope, and you see something fishy, you're going to refer out just to
Right.
protect yourself. And that's it.
Yeah, no, and it doesn't make sense because, the difference of the physician model versus NP is that physicians technically should they, that's a different story, but, we see all the time, nephrologists practice in primary care, but they don't give vaccines, and I'm like, how does that work? But that's a whole nother story. But the bottom line is know what you're going to do before those encounters happen. If you see a male patient and they say, oh, I ran out of my acne medication, can you please, it's going to be hard for me to get to my, no, I'm sorry, I can't. Done.
How
Yeah.
about if they run out of their Valium?
Their Valium? No.
No.
No. A male patient?
Oh, no, I have females.
Oh, female. I mean, look, you have to decide.
Comfortable with.
Right.
Right, and you guys that are F&Ps, they're going to be asking you as well to refill all this Ambien and Xanax and diazepam, and you have to decide what you feel comfortable with and what you don't. One of the attendings in my practice gives out all this kind of stuff, and then they call me and they're like, why won't you refill my TID?
Right.
I'm like, gee, I don't know.
Yeah. So I mean, that's the other problem that we're in the midst of right now. Something called the opioid epidemic. Although those are benzodiazepines, but again, you want to be careful and not contribute to the problem. And whatever you can do to be safe, it's your license at the end of the day. You earned it, but they could take it away from you. So you don't want that to happen. You know the answer to this because we just discussed it. It is illegal for a physician to charge an NP. Is it right? So that's false. So what does this mean? It means, again, it's your responsibility to know what you can and what you can't do. You can't say, oh, well, the physician said I could do brain surgery. Well, the physician said. No, you can't because the doctor said that's not acceptable. You can't do it. And you will find yourself in these situations. Oh, just do it. I'll watch you. No. Now we get into situations where there's again, more gray. Let's talk about trigger point injections. This is a question that comes up a lot. Can I, as an NP, do trigger point injections? Well, it's an injection. It's not surgery. New York State wants to know that you've been trained and are competent in doing a procedure. So if you can show that you went to a training course and then you were supervised by doing 50 trigger point injections, that's okay then. You could do it. Because again, the Nurse Practice Act doesn't include every single scenario. But you better make sure that whatever you're doing, you can back up with education and training. Now, there are certain things that we are explicitly prohibitive from doing, such as surgery. Now, people will always say, but what about INDs? What about this? What about that? I'm talking about surgery in an OR, opening somebody up. No NPs are doing that. So that's what I'm talking about. All right. So as we're talking about all these statutes and laws, is it difficult to change laws in New York? Yes, it is. It's very difficult. And it's partially difficult because of the legislative session. So this is multiple choice, no reason not to guess. But when does the legislative session run in New York? January to December, January to June, or July to December? B. I heard B's, C's. The answer is B. It's January to June. It's 6 months. There's only 6 months every year that laws get passed in New York State. So we're coming up on this June 30th time frame, which means that there's only about another month and a half or so. Is it a month and a half? Yeah, a month and a half. Today's May 1st. To the end of this session. So lots has to happen in order for legislation to pass, and I'll get into a little bit of that too. January to June. So not a lot of time to have bills drafted, sponsors sought, key legislators lobbied, and have legislation successfully passed within one session. Now, here's the good news, that each legislative session is a 2-year cycle. So 2018 is the second year of the 2-year cycle. So if a bill was introduced last year and wasn't acted on, it's still live in 18. But I will tell you this, if any bill doesn't pass by June 30th of this year, it has to be completely reintroduced starting in January with a new number, a new bill number, and possibly a new sponsor. Because do you know what's coming up in November? Is Election Day. Every office in New York State legislature is up for election. It doesn't mean everybody's has an opponent that's running against one, but the Assembly and the Senate in New York is all up for vote. So this is an important time. And if there's ever a time you want to talk to your legislator, it's now. Because they want your vote, and you want to ask them, what do you think about nurse practitioners? And they say, I don't know what a nurse practitioner is. Well, that would be a check in the column for me. And that would be your opportunity to educate them on what a nurse practitioner is. And I will get to it in a slide or so, what our legislative bills are that we want to pass in the coming days. And are you supportive of that? Because let me tell you this, Not everybody likes nurse practitioners. There's this group of physicians that are part of the American Medical Association. They don't really think we should be doing what we're doing. And they oppose everything that we try to move forward. In fact, not only do they oppose what we're trying to move forward, they're trying to take us back 20 years. So, legislators do not wake up in the morning and say, how can I help NPs today? They don't. So it's up to us to tell them, I live in your district, my patients live in your district, I am a healthcare provider in your district, my patients are healthy because of me. You don't want to say it's that way, but you want to advocate for your patients and you want to show that you are a voter, your patients are voters, and your patients want to continue seeing you because they like you. So the saying is, if you're not at the table, you're on the menu. So we need to be at the table, the health policy table. So what can you do? You can join the Nurse Practitioner Association. So I hope most of you are. By show of hands, is anybody a member of the NP Association? 1, 2? All right, well, I have a credit card swiper. We'll talk about that by the end. But this association, I'm a member of it. I pay my dues every year. That's how I started out. In this association. We are the ones who have presence in Albany, that when legislators have questions about bills, they call us. They don't sort of just make a decision based on what they heard from medicine. They'll actually call us, and we do a lot of that, but there's other benefits. I'm not going into the mission and vision, but basically we exist to eliminate every practice barrier that exists for nurse practitioners in New York State. Now, there are issues that are beyond New York State. There are issues that are at the federal level that it doesn't matter if you're an NP in California, in New York, or Texas, or anywhere in between, but we have the same restrictions. Those 3 big issues are home health. NPs are, if an NP orders home health, that home health agency is not getting paid by Medicare. So what does that mean? It means NPs are not ordering home health. This needs to be fixed in Congress. There's a bill, but that's what AANP is working on. That's not to say that we don't have a role to contact our congressman or woman, but that's not an issue that's unique to the states. That's an issue that's across the United States. That's issue number 1. Issue number 2 is accountable care organizations, ACOs. It's technical, but NPs cannot participate in ACOs, so that's an issue that is being worked on. And the last issue, which is my absolute favorite, is diabetic shoes. I kid you not. NPs, an order by an NP for a diabetic shoe will not be paid by Medicare. So there's a bill that would allow NPs to be recognized as providers so we can order diabetic shoes. This is insane. I've been to Washington, D.C. I've spoken to legislators. They all say the same thing to me. This is a no-brainer. I say, if it's such a no-brainer, why have we been working on this for the last 10 years and it still hasn't been fixed? This is the reality. This is the reality. I say, in New York State, I could prescribe medical marijuana. I can prescribe the strongest opioids to kill an elephant, right? But I can't prescribe a diabetic shoe for my patient who needs it. It's insane. It's insane, but that's the reality. Social media, right? So social media, it's all about social media today. And the NPA has a presence on Twitter, on Facebook and Instagram. And, you know, I used to put up the slide years ago and say, oh, we're on Facebook and blah, blah, blah. But the good news is that when we post something, it's a positive NP story. So I've had people come to me and say, you know, I clicked like on one of your stories and my family member came up to me and said, is that what you do? Is that what a nurse practitioner is? Because there's people who still don't know what NPs are or what we do. So we're only going to have good stories about NPs here, usually New York based. So I encourage you to follow us on social media as well as to engage with us on social media because it does make a difference. Nurses are the largest part of the healthcare workforce in the United States. There's 3.7 million nurses in the United States. there are about 269,000 nurse practitioners. When they do that Gallup poll every year as the most trusted profession, it's nursing. Year after year after year, it's nursing, except in 2001 after 9/11 when it was firefighters. But every year has been nurses. We need to leverage that and tell our lawmakers we are your biggest healthcare profession. We are high-quality providers, and you need to make the practice environment better for nurse practitioners so we can care for patients and not have to worry about writing for diabetic shoes that my patient can't get. This is what it comes down to. So we need to leverage that power. This is a very busy slide, but it's just an example of some of the things that this association has had to do in order for us to be where we are today. So 1988 was the year that NP title and scope was passed into legislation. So prior to 1988, you could not have called yourself legally a nurse practitioner in New York State. That's not to say that there weren't NP programs training NPs, but as far as applying for a license in New York State, you could not do that. 1988 was a big year, and that was a year, however, that required us to have a written collaborative agreement with a physician in order to practice. Another year that I highlight, 2011, NPs can sign death certificates as of 2011. That's a big deal. You may say, I will never have to sign a patient. I work in women's health, and they're not going to die from what I do, hopefully. But that's an advance for the profession, and that gets us closer to one less barrier that stands in our way. The Modernization Act passed in 2014, became effective in 2015. Just this past session, 2017, the DNR bill passed. I'm going to talk about that in a minute too. But we're making progress, but we're not there. About the Modernization Act, it went into effect on January 1st, 2015. It actually is set to expire on June 30th, 2021, which is the end of that legislative session. It goes away if we do nothing about it. Now, we're not going to let that happen. We're actually going to use this as an opportunity to make enhancements to the law because it was hard to pass this. It took 8 years to pass this legislation, and we're hoping that in just a few short years, there's an opportunity for us to actually make some more improvements. Very, 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 very basic. There are two houses of government in New York State. It's the Assembly and Senate. Each of you fall into a senator's district or an assembly member's. There are 150 members of the Assembly. There are 61 members of the Senate. They're both equal fundamentally. And in order for a law to pass, it has to pass separately through both houses. So you have a Senate version and you have an Assembly version. If one passes the Senate but doesn't pass the Assembly, that bill doesn't go to the governor for signature. The identical bill has to pass both houses in order to get to the governor's desk for signature. Interesting fact here we're talking politics a little bit. So the Assembly is overwhelmingly Democratic. So as an NP association, we're nonpartisan. If you support nurse practitioners, we will support you, whether you're Democrat, Republican, or independent. But the Assembly is Democratic, and the Senate is, well, it remains to be seen what the Senate really is, because there was just a special election last week that technically gave Democrats a majority by one in the Senate. However, Brooklyn Senator Simcha Felder, anybody in Simcha Felder's district, has decided that he's going to caucus with the Republicans, even though he was elected as a Democrat. So this is like not dirty politics, but this is like, I could spend all day talking about this. But yes.
So what does that mean? He switched parties?
So no, he didn't switch. He didn't switch parties. So in allegiances. So in 2011, a group of 8 breakaway Democrats formed the IDC, the Independent Democratic Caucus, in New York State Senate. These were elected as Democrats, but said, we're not going to agree with what all the Democrats do. We're actually going to side with the Republicans. 8 breakaway Democrats did this. Sen Simcha Felder, who said, I'm kind of not following any of you. I'm just going to do my own thing. I'm going to do what's best for me and my constituents. Just a month ago, those 8 Democrats united with the larger Democratic Party, except Simcha Felder, who said, that's very nice that you're all aligning, but I'm still not joining you. So technically, as of right now, New York State has a majority of Democratic members in the Senate, but it's actually a Republican majority. I say this because this is the crazy politics. You can't anticipate this stuff happening. This is what happens. So this has an effect when we're trying to pass legislation that we need to make sure we have legislators in both parties that are friendly to NPs. So that is New York politics. Speaking of New York politics, there are 3 main bills that are part of our legislative agenda for the rest of this year. The DNR bill passed last year, so that's good. But it didn't do everything that we wanted it to do. So, for example, this law has not gone into effect yet. It actually goes into effect in 3 weeks. For DNR, if a patient has the capacity to determine themselves if they want to be a DNR, an NP can sign it. Well, we'll be able to sign it in 3 weeks. But if that patient doesn't have capacity and has a healthcare proxy, and that healthcare proxy says, I as your healthcare proxy am saying no resuscitation, NPs cannot sign that order. Yes?
Is the role for a nurse practitioner for primary care setting and acute care setting different? Because I've seen DNR orders by NPs before.
They may be signing DNR orders, but legally, it's the same. An NP in New York State cannot sign legally a DNR order, whether you're acute or. They could put the order in, but it's got to be signed by the physician. So that is the DNR issue. So there is a bill that we have. This is actually only in this session. This is the Senate version, but there is an Assembly version that we hope to pass in the next few weeks. So it fixes the issue of a patient having a healthcare proxy, so NPs can sign all DNRs regardless of where they originated from, whether the patient themselves or from their healthcare proxy. But as of today, if nothing happens, in 3 weeks, NPs will be able to sign DNRs if a patient says, I want to be a DNR. Workers' compensation. In New York State, NPs cannot treat and bill any injured worker on the job and get paid by New York State workers' comp. We are not recognized as providers in the New York State workers' compensation system, which makes 0 sense. You can have an injury at home, hurt your knee, go see your nurse practitioner, use your private Aetna insurance, get an x-ray, get a referral for physical therapy, get some anti-inflammatories, and you're on your way. That same injury happened at work. You cannot see a nurse practitioner because the nurse practitioner is not going to get paid because they're not recognized under workers' compensation law. So legislation has to happen. You know, I wish I could call the Board of Nursing and say, hey, Board of Nursing, fix this. They say, that's very nice. We agree with you. That's a problem. Get a law changed. Get a bill passed. And this is what it takes. This is active participation. This doesn't happen organically. This happens because there's a problem. There's identification of the problem, and we go to our lawmakers and say, fix this. This is a problem. So that is workers' comp. Civil service bill, the BSN tenant bill passed last year, so that's good. This is another bill that is part of our legislative priorities, the clinical preceptorship tax credit, which would give preceptors a tax credit up to $3,000 a year for precepting students. Right now, as preceptors, what do we get? We get zero. Unless you get paid extra by your institution, which you would be omitted from applying for the tax credit if this bill were to pass. But, you know, look, I love to precept students. I have since I've been in NP, but the reality is it slows you down. It makes you less effective. But I feel it's my give back to the profession. But the reality is I lose money. You know, I'm not as efficient. I'm not seeing as many patients. So at least this would incentivize providers in New York State to say, hey, why don't you precept students? So it's up to 3 students a year, which it's $1,000 per student, up to $3,000. It has to be 100 hours per $1,000 of credit. But this is dollar for dollar. So in New York State tax, this is like right off your New York State income tax. And of course, this is controversial because New York State would lose money, but there's not many of us that are really precepting and would be, if you work for an academic medical center and you're expected to precept as part of your job, you don't qualify for this. But the idea is that, what about that small practice? What about those 4, providers, whether they be NPs, physicians, or PAs? Why not incentivize them to precept students? Because the problem we have is there's not enough preceptors in New York State. It's not just unique to New York State, it's all around. And again, one of the other differences between physician training and nurse practitioner training is that physicians have residencies that are paid for by CMS money. This is for Medicare money, billions and billions of dollars. We do this on our own. We go to school and we get clinical placements at the same time. And I'm not here to talk about residencies, whether they're good, whether they're bad. It's just the fact of how we're educated as NPs today is different than how physicians are. So, and then another bill passed last year which allows NPs, if a public entity wanted to put up an automatic defibrillator, they actually need a written agreement with the physician to do so. But there were NPs that were in rural New York State that said, I'm the only NP in the area, and somebody approached me, local gym wants to put a defibrillator up, and why shouldn't they? And we agreed with that. So we were able to get this law changed last year that allows an NP or a PA to sign an agreement so a public entity can put in a defibrillator. This law went back years and years ago when defibrillators were this big and were a little bit complicated. Now they have 2 buttons on it. A 5-year-old can operate a defibrillator. So this is really a no-brainer. So here are the federal priorities that I mentioned. Very, our diabetic shoes, our ACO, and our Medicare home health. Some of the other things that the Nurse Practitioner Association does is you get updates about New York State practice issues that are unique to your practice in New York State. We have a quarterly journal that's delivered to your mailbox. We have an electronic newsletter. And although the state says April 30th, which was yesterday, we're going to extend this, if you sign up today, for the membership campaign. So student membership is, how much is student? $75. Say again? No, it's under 80. I think it's 75. So if you join as a student, it's 75. If you join as a student, that's good for a year. And then because it falls under this campaign, we give you a $50 credit to renew next year. Or that $50 could be used towards one of our conferences off of registration fees. Now, membership prices do go up once you're not a student anymore. But if you're a student and then graduate, there's a transitional rate between full price and student price, and you could use that $50 credit. So that's automatically used. You don't have to do anything special to do that, and that's a great way to become involved and do it at a discount. We were just in Albany 2 weeks ago. This was a picture from 2015, but similar type of thing. We went up to Albany. We do this once a year. Has anybody been to Albany and legislator and went, did lobbying? All right, so a few of you might have went with NYSNA. We're not a union. The NPA is not a collective bargaining agency. We are here to promote the profession of nurse practitioners and to eliminate barriers. This conference is actually this Saturday coming up. It's up in Rochester, but we do a one-day conference, and we have an annual conference in Saratoga. Well, this year it'll be in Saratoga, and it's a 3-day conference, and it's a good way. Most of our speakers are nurse practitioners. It mostly has a primary care focus, but it's a great opportunity to network and see other NPs. Each region of the association has its own designation. So there's a Brooklyn, Queens chapter of the association, which has local monthly meetings. These are a great way to network as well. I've seen people get jobs at these meetings. We send out emails. You sign up and say, oh, I want to go. 99% of the time they're free. You don't have to pay extra for them. You just get to go to a meeting and get a dinner and listen to a boring drug rep. But hey, the meal is free and the food is usually pretty good. So that's our annual conference. And of course, there's a student discount if you go as a student. And then this is a really interesting program. If you're interested or open to the idea of practicing in upstate New York, Iroquois Healthcare Association is having a tour, like an all-expense paid tour, June 6th to the 8th, to go to 2 or 3 facilities in upstate New York and experience upstate New York. And there are jobs available for NPs. And this is, again, it's a soup to nuts kind of tour where you could take the tour and not necessarily have any intention of practicing upstate New York, but you get an all-expense trip paid, including transportation, meals, and a 2-night luxury hotel accommodation. Upstate New York has a problem attracting nurse practitioners, all healthcare providers. So the Iroquois Healthcare Association had reached out to us and said, how can we promote upstate New York to people who have no intention of ever practicing in New York, upstate New York? So this information is also on our website. If you go to thenpa.org, and you can find out more information about that. And that is registration for that will close in 2 or 3 weeks. So that's a lot of information. I know you all have lots of questions for me. What questions do you have?
I want to know about residencies.
Residencies, okay.
I know that they created a residencies for the MPs, but what's the barometer for the other NP practices?
So residencies are a fairly new concept for nurse practitioners. And there are a few in New York State that they're essentially privately funded. So somebody is contributing to these residencies. One that I'm particularly aware of is through the Community Healthcare Network, which is a FQHC. They have both a family NP as well as a psych NP residency, which is a paid 1-year rotation, like 1-year intensive. And this is what we're seeing pop up. There's no requirement for residencies in New York State. It's not part of the Board of Nursing. Could we see that be the case at one point? Maybe. But right now, any residency in New York is going to be post-grad. So you're going to graduate from an NP program, you're going to get licensed as an NP, and then you apply to one of these programs to do whether it be 12 months, 18 months, 24 months, but they're all funded in some private way. There's not a standard for NP residencies that exists today. There's been some federal money that's been pilot projects, but it's in like 5 locations throughout the United States. So the question is, should these be expanded? Could they be expanded? How would they be paid for? Lots and lots of questions. So I don't think we'll see residencies as a requirement in any time soon, but certainly there's more and more popping up that you can do. And if they're in another state, you have to get licensed in another state in order to be able to participate in it, which could be a long process. But that's what I know about residencies.
Well, anything that you know, you posted for us because we don't really know where to garner that information.
So there's really no central repository for residencies. My recommendation to you is just to Google them. But how can you get in touch with me? Email is the best way. I will tell you my email address. It is sferrara, Ferrara, at thenpa.org. So it's sferrara, Sferrara, at thenpa.org. And that's the best way to get in touch with me. Other questions? Yes? I do. So not regularly. I kind of fill in holes in our schedule. So at Columbia, I oversee our faculty practice. So we have a NP primary care faculty practice with 4 locations and house calls in and around New York City. So that's kind of keeps me busy most of the time, and I oversee that practice. And when we have a hole in our schedule, I'll kind of fill in and see patients, and I like to. Unfortunately, all my other stuff keeps me so busy that it takes me away from patient care, but I'm happy to still call myself a clinician. I saw patients on Friday, so I'm glad to stay in the mix because I think that's important. I mean, it's why I became a nurse practitioner to see patients, but I've been fortunate enough to get involved in some of areas that hopefully broaden our professional scope of practice. So, thank you. Yes? Do I see the DNP being a requirement? So this is a question that's asked a lot. And I will tell you that it will never be expected that you have to go back and get your DNP if you aren't one and it is made a requirement. They will usually grandfather everybody in. But I do know that the National Organization of Nurse Practitioner Faculties just advised that by 2025, all NP programs are converted to a DNP. Now, they tried that once before. AACN said by 2015, all NP programs would be DNP. That didn't happen. But I do see more and more movement there. There is not one state that requires a DNP for licensure as an NP versus a master's. Will that change over time? Yes. I think one day will not be an issue because every NP program is going to have them, is going to make it. But as far as it being mandated, as far as you having to go back, that's not going to happen. But I'm an advocate of the DNP. I think you should do it. I also edit a journal that's called the Journal of Doctoral Nursing Practice, JDNP. So I believe in the DNP and what it does, and it expands sort of it doesn't expand practice, which is a lot of, people will say, well, if it's not going to let me do anything else, why should I do it? Because it allows you to look at sort of the healthcare system differently, and evidence-based practice and cultural competency and some of the things that were not included in the master's level, you get at the doctoral level, and I think that's important to move us forward collectively. Question? Good morning. Good morning. Two questions.
One, it's not a requirement to get board certified to work as a nurse practitioner in New York State.
In New York State, that is correct. It is not a requirement to be board certified for licensure.
And number two, what's your best recommendation besides joining the NPA, NPA, in terms of earning a job? And getting a job right now, it's very saturated, very difficult, networking is key. What else do you recommend?
Yeah.
Their job?
Yep. I mean, it's all about networking.
Everybody's asking for experience 2 or 3
Yeah,
I'm starting to look right now at my hospital, and they want acute care.
right.
They want, within 2 years, you gotta be acute care. For anybody who's going to hospital, they want acute care.
Yep.
Within 2 years.
Right. So that's a good point. So this is a problem that is sort of growing day by day, is that a lot of institutions, particularly in New York, are saying, if you were going to work inpatient in this institution, you have to be an acute care NP. And that is not necessarily, and one of the areas that conflicts with is the emergency room setting, because acute care doesn't encompass peds and women's health, which, believe it or not, is a big part of what you see in an ED. So these hospitals are trying to comply with a standard that doesn't exist, in all honesty. This is saying, well, we think you should be an acute care NP if you're going to work inpatient. But New York State does not require that. So this is sort of a movement that is happening amongst the institutions themselves and saying, acute care for inpatient, outpatient, family. To get back to how do you find a job, it is about networking. I mean, I've worked at Montefiore, now I'm at Columbia, and I remember I was sitting in orientation at Montefiore, and they made us feel that they said, for every one of you sitting here, there were 1,000 resumes that were underneath yours, and you're lucky to be here. Now, I guess that's supposed to make you feel fortunate to have a job, but the reality is, how do you get your resume from the bottom or middle to the top? And the only way you could do that is by knowing somebody. And that's how I got my job at Montefiore. I mean, I knew people in the department, and they hired me before I even spoke to HR. So I think that's the way to do it. You have to be cognizant of what's out there. I mean, Indeed.com is one of the best search engines to search for jobs. And really that's, and you may have to take a part-time job first, and see if you could work your RN job and NP job, which is hard. I mean, that's not easy to work 2 jobs. But, I think NPs are in a position where you don't have to take the first NP job that comes up. Be a little bit, say I'm not just going to take the first job that comes up. I'm going to use my discretion and say, this seems like a good fit for me, or no, this is not definitely a good fit. So, there's no rule that you have to work as an NP, within 6 months. I mean, it's better if you can apply what you've just learned sooner. But, don't take the first NP job, because there was a time where it was really hard to get an NP job, and you would take the first thing, and people were miserable and say, this is not what I became an NP for. I was making more money as an RN. I had a better schedule as an RN. This is what we hear. But, we don't become NPs to make a lot more money, because you may be able to make more money as an RN with overtime. But it's a different aspect of patient care. You are provider, you are writing prescriptions, you are educating patients about their health conditions. It's a completely different dynamic.
Do you think there'll ever be a bill where, you know how like physicians get the 100% reimbursement,
Yeah.
NPs get
Yeah, 85%. So it is my hope. So Medicare is the one who set the standard in 1996 that said NPs will get 85% of what physicians get. Now, I believe we should get equal pay for equal work. The treatments we give, it should be outcome-based. Pay me based on what my patients, how well my patients are doing. So it is my hope, but it's very difficult, because that means more money for Medicare. Medicare would be paying us more money. So, right now, the way any provider is reimbursed is controversial. Everybody's saying we're not getting paid enough. But what really irks me is that, say you want to open up your own NP practice, and you're going to see Medicare patients, and you have less than 3,600 hours experience. So now you have to pay rent, and you have to buy supplies, and you have to pay a collaborating physician, and you're going to get 85 cents on every dollar. That's not really a winning proposition to me, because guess what? When you have to buy like tongue depressors and otoscopes, you don't get a discount because you're an NP. You have to pay the same price that a physician would be paying. So it really is a hard case to make to say, I want to open up my own NP practice. And if you want to do that, more power to you. But what I'm seeing is a lot of people opening sort of house calls practices, something that doesn't require a lot of overhead. So house calls, you could do house calls. Or some other specialty type practice that doesn't require sort of the traditional upkeep of a physical practice. So I hope we see it. I don't think we'll see it anytime soon. That's yes.
I was giving at the brochure, so I didn't hear what you said. I'm sure you encourage everyone to sit for the boards and ask.
Oh yes. So the earlier question was.
Because I heard Mr. Ramadan already saying that it's not necessary in the state of New York, and I've been hawking them.
Yes. So
Closely, you'll see their heads are hawked.
So technically, in New York, and you will receive your NP license in the mail before you sat for the board. But please sit for the board. You will not get a job in any institution if you're not board certified, and no insurance company will credential you if you're not board certified. So, for all intents and purposes, take the test, pass it. It doesn't matter if you take ANP or ANCC. They're both recognized. Or is the Women's Health have a separate?
Yes, they do. NCC, they all know it.
Okay, so whatever it is, please get board certified. I've hired NPs who, completed their NP programs back in the late 80s and never got certified. Well, new job, new insurance requirements, you need to be board certified. They had to go back and take the test. And after you pass a certain window, you're not eligible to sit for the test because your schooling was X number of years beyond of what they allow. So please take the test. While it's not required for licensure, it's required for everything else if you're going to practice. So.
And the sooner the better.
The sooner the better.
While it's fresh in your mind.
I will also tell you, do they have to take a review course?
Well, listen, I don't know, it's up in the air.
Okay, it's up in the air. But I can tell you that if you are a member of the NP Association, we have 2 programs that offer discounts on the online review course. One is Fitzgerald Health. So if you sign up through us, you get 15% off. And she does a lot of programs in New York City. So that's one. And the other one is Amelie Hollier, AHEA. She's mostly online. And you get a discount for being an NPA member. I believe that's 10%.
No, it's just FNP.
Hollier doesn't? Okay, that's it.
But I guess Barclay has a review 2 weeks to get a discount.
Does Barclay do
They have online ads.
women's health?
No.
Oh,
They
oh.
do. That's another cup of coffee.
Oh, that's another cup of coffee. So,
Forget that. So let me just add something else.
add away.
To Dr. Ferrara's talk. I will tell you this, one of the FNPs that graduated just a couple of years ago actually did exactly that. He opened up a house call. And he lives really close to me. And when my son was sick, someone said to me, why don't you call him? I didn't realize, so I called him and he came to the house. You have to see, he has everything he needs right then and there. He did all the cultures, he treated him, he set up everything right then and there, okay? It was really, really, really great. So that's one thing. And the other thing is, one of the other FNPs that he was very good friends with opened a practice, Dr. Ferrara. They bought a practice with, I think, 3 physicians in him, equal partners, in this beautiful outpatient setting that's thriving away. They have office hours 6 days a week. He wants me to ask you about admitting privileges, because in the state of New York, he doesn't have admitting privileges, and he wants to talk about that with you.
Okay, so send him my way,
I will send
as long as he's a member of the association, and we could talk.
You should say that. Look, we've been friends for a long time. I said to him, I said, you are still a member, aren't you? And he sort of looked down and said, oh, yeah, I am.
I could look him up in the database. So I mean, again, this is why we exist, right? So we want to help NPs answer these questions. there's technically nothing in New York State law that prohibits admitting privileges. It's that institution. Because I have admitting privileges at Columbia. So, yeah. So it's that institution who said, no, NPs, you can't have admitting privileges. And do you think it's hard to pass a law? It's hard to change bylaws in a hospital, too, to get a physician board to change their bylaws that say we're going to allow NPs to have admitting privileges. So
It's the same hospital, which shall remain nameless, who the administrator of the department said to me, but why should a patient see you when they can see a physician?
yeah, so that tells you what kind of support that is going to be there for that battle. And these things don't happen overnight, right? So, you may never go to Albany, you may never talk to your legislator, but that's not the only place health policy exists. It exists in your institution. And you see something, you say, wait a minute, there's 50 NPs here. How come we don't have a voice? How come we're not involved in this clinical guidelines revision or this other clinical issue? That's where we belong. So get involved. Don't take no for an answer because it's easy to say no and it's easy to blow things off. But make sure you are involved. So Fitzgerald, I mean, it looks, they do have a women's health? This is on her website. I don't know.
I can check it out. Right? NPWH has a review.
Oh, okay.
It was updated, so they have their own review.
So-
And lots of times the women's health on Fitzgerald and Barkley are not written by women's health, so that's into the context.
Right, so listen to Professor Steinfeld here. And, okay, so that's it. Any other questions? Yes?
So let's say I pass the board.
Yeah.
Let's say I don't find a job. How does that affect me when I get ready to be certified? What's for CMEs or CMEs?
So you definitely accrue CMEs as long as you go to classes, during that time. The threshold of practice is very low. It's only 1,000 hours in 5 years. So that end, I understand, and I haven't seen this myself, but somebody told me that ANCC has eliminated the practice hours requirement from recertification, which I don't think I agree with that. I think if you're an NP, you should be seeing patients in order to be recertified, but that's what I heard. Now, that's with ANCC. AANP still requires practice hours, but you could get those practice hours in like a year, if you started working a year. So definitely continue the CMEs as you take them. And it depends on, how many you take. Just look at the criteria. If you take 150, that allows you to recertify. One of the big parts of recertification now are pharmacology hours. Everybody now has some requirement, whether it be 30 hours over 5 years, but look at those pharm credits because it takes a lot more courses to accrue pharmacology credits than it does for a CME because there's just not as much pharmacology out there. So keep watch on those. Anything else? Yes. How do I sign up to be part of the NPA? I'm glad you asked that. I have a swiper, and I'm not kidding. If you fill out the application and have a credit card, I will be happily to take those from you, and you will be a member before you leave this classroom today. And your other question was?
Any recommendations on how to work with leadership?
Leadership.
Yeah, like how to get into leadership in our role as
As an NP. Well, I think, so the question is, how do you get involved in leadership? Yeah, I think you have to start somewhere, right? And I think it's getting on a committee. You don't start to say, I want to chair this committee on day one. How do I get involved? Is there a start a journal club, that could be 5 people, that, clinicians, and see where that goes. I mean, you have to try certain things. It's not going to necessarily come to you. Sometimes you're lucky and you get tapped on the shoulder and somebody says, come with me. That is not always the case, but look for a mentor. You know, see if somebody's willing, ask somebody. You know, people may not necessarily, look, we're all busy, right? We all have a million things going on. So somebody may not say, oh, why don't you do this? But ask them. It's okay to ask questions. The worst they could say is no. If you don't ask, then you'll never know. So ask questions, ask to be involved, ask to be put on a committee, and you know, that's the best way to get started. And then next thing you know, they'll make you an executive director, and you say, how the heck did I get here? And they won't let me go. So, yes?
Did you have a mentor?
Did I have a mentor? Yes, I did. I didn't have a clinical mentor. I had an association mentor.
What were some of the things your mentor did for you?
So she said, you're coming to this meeting. You need to come here. You need to do this. And I was sort of dragging and screaming the whole way and said, no, I don't want to do that. But there was obviously a part of me that I wanted to participate. But I think I wouldn't have been as involved as I was if it wasn't due to somebody inviting me in. And I think that was the luxury that I had that a lot of people don't get. So that got me more involved than I would have on my own. So our joke is like, if you go to one of our association meetings and they're like, you know, looking for a secretary or a treasurer, the joke is don't go to the bathroom, because by the time you get back, you might have been elected treasurer or secretary or something. So you definitely want to stay present, because you know, if you're not in the room, they'll elect you to do something. But the good thing is there are opportunities for this. And believe it or not, for recertification, if you're a member of a board, that counts as one of your categories. You have to be a member for 2 years. But that counts as one of your categories of recertification, because this is for ANCC, because you're actively participating in the professional development of your association. And that's important. You know, it's not all about clinical practice. If it was about clinical practice, our jobs would be done, right? Because all of the data that's out there on NP says that we provide just as good, if not better, care than our physician colleagues. But why don't we have all the access? Why don't we have you know, all of the sort of freedoms of practice? Why do we have to have a physician sign home care orders as opposed to NP? There's a lot more to our profession and practice than the clinical aspect of things. There's a whole world outside there, and I encourage you to sort of dip your toe in the water, write to a legislator, go to a meeting, see what it's all about, and you know, because it would be a very boring job if all you did was 9 to 5, Monday to Friday, you know, managing diabetic patients or, you know, doing annual women's health exams. There's more beyond that. And look, use me as a resource. Email me, whatever I could do to help. This is why I do what I do. So, question?
It's not really a question, but it is.
Yeah.
Thank you for coming in.
Oh, you're welcome.
I really learned a lot, and what I wanted to ask you is, have you ever thought about like going into a higher office? Because I feel a lot of the reasons why physicians and care providers are not being reimbursed appropriately is because everybody that sits on the top and makes decisions, they don't know what we go through.
Right.
They don't know what we go through emotionally, mentally, physically. And even when it comes to institutions, how when they sit on their board meetings, they went to school for business or whatever else. They have no idea and no clue that a diabetic foot, that's implied. So I'm thinking, I know you like practicing, but I think you'd be great. No,
Thank
seriously.
you. I mean, I've tried to have. Thank you. I mean, I think I appreciate that. I really do. I don't know if political life is for me, but I'm lucky to be in a position where, you know, we talk about our political action committee. It's called a PAC, and you know, this is something that we raise money for every year, and it's those opportunities that. So just last week, last Monday night, as a matter of fact, I was invited to a dinner with Assembly Member Carl Hastie, who is the leader of the Assembly. Now, I'm having dinner with him. There's only like 14 people in a room. So this is my opportunity to, while I may not be that person who can vote per se, I have his ear for 2 hours. And we talked, he's a fan of Prince, and he's a Dallas Cowboys fan. So we talked, and of course, as we're talking, I'm saying, so I'm a nurse practitioner, I'm part of the Nurse Practitioner Association, and we're gonna have some bills that are coming up, and the Speaker of the House, the Speaker of the House and the Senate Majority Leader are the ones who control the agendas in their respective houses. So you can have a bill that passes out of committee, but if it doesn't make it on the floor calendar to be voted on, the bill can sort of go into this gray area and never be heard. So you want friends who are the leaders of the Assembly and the Senate, because they're the ones who say, yeah, put that bill on the Senate or on the Assembly floor and we'll hear it. So I feel that I'm effective in doing that now. At one point I thought about sort of politics, but then you need to raise money. I'm not good at asking for money. I'm good at asking for membership. But I'm not good at asking for money and those types of things. So I appreciate that. But I feel that I'm able to sort of influence lawmakers in ways that I have the position that I have with the NPA. So thank you. Anything else? Yes. So this is a common question. If you want to be an FNP and branch off into derm. So, you can, but be careful. Don't all of a sudden say you're going to start doing Botox and all of these specialties without training. Now, you as an FNP, can you take a Botox class? Absolutely. But be careful. Just be careful. Make sure that you can document that you went to X training for fillers, that you provided, under the supervision of a dermatologist, and then go off on your own and do your own thing. So, what we want to be careful about is that, somebody becomes an FNP and the next day they're kind of opening their own business, some crazy thing. I'm not saying derm is crazy, but you need to have the experience and training to justify your existence. Once you have that, then go for it. But don't just say, FNP, graduating, I'm going to do derm. Now, can you work for a dermatologist? Sure. I wouldn't say you go off on your own at that point, but get some experience with that derm and then figure out where you go from there. Because a lot of NPs, because, this is part of the problem of our healthcare system, right? Because derm is lucrative and it's usually cash, and it's unfortunate that you can make a better salary doing something like that versus caring for the underserved, and for the people who actually need primary care. But that's a whole nother topic. But there's no reason why you shouldn't be able to utilize your skills and your knowledge to go into an area that you're passionate about. All right, so I kid you not. So this is I used to have a swiper, but now with chip card readers, you can't swipe anymore. So now I have a chip reader. I'm fancy. So no pressure, but
I prepped them for you.
you prepped them.
I told them to bring their prep cards.
All right. Well, then we're in a good.
Tell about the license plates.
Oh, the license plate. If you're interested, so just as of 2 months ago, New York State allows you to order you can always order an RN license plate, but these are brand new. So you could get an NP license plate that says nurse practitioner on it. You have to be licensed, of course, but there's instructions on our website on how to do it. So this is really cool. So I have one on my car, and I'll tell you, it is a conversation starter. What's that?
But that doesn't entitle us to park in the
No,
physician park.
no. So this doesn't get you physician parking. That's why you have to talk to your institution and say they need to recognize NP plates. So you are getting yours? So these are real good conversation starters.
Just a quick question. Why can't nurse practitioners park in the physician parking when they are providers at the hospital, just like the physician?
I think they should.
Justify it if the ticket is given?
Probably not, but you know, but that institution has some rule somewhere that says physician only parking. That's why you need to go to them and say, hello, I'm an NP, I have my nice NP plate here, why don't you allow me to park here? And ask the question. I mean, you know, not contentious, not saying you have to do this, but it doesn't make sense.
I believe that nurse practitioners are still recognized under nurses. So as far as like they have nurses week, they have providers week. When you go into any selective hospital or wherever you go and you're under an organization, you're still under the nursing portion of for nurse practitioners. Are we ever going to get to the point where we're going to have our own?
So you mean as institutions?
Yeah.
So
When I was asking the nurse practitioners at my institution,
Yeah.
where they're recognized under, they said they're still under NYS.
well, that's a whole problem in and of itself. Now, there are unions in New York State. NYSNA is the biggest one. And a lot of NPs I know are not happy with them because they don't represent NP issues. Because their issue today and always will be patient-nurse ratios, right? So I worked at Montefiore. I was there with fellow NPs who were part of the union, and they said, you know, what's up with this? Why do we still have to, you know, thumb in and, you know, we're professionals, and I agreed with them, but that's part of their contract. There is an NP week. There's an NP week every year. It is the second week of November. It starts usually around the 8th of November and goes that whole week. In New York State, we get a proclamation from Governor Cuomo that says this is officially NP week. We at the association, we promote it as much as we can. We encourage institutions, you know, and I've heard this from institutions, oh, but we do Nurses Week in May. This is not Nurses Week, this is NP Week. So it's a little bit of education, it's a little bit of saying, hey, look, did you know that this week was recognized? It's asking them to plan for it. And I've seen institutions, NYU has done a good NP week. Sloan Kettering has done an NP week. So it's starting to spread. They just need to know about it. And it could be you saying, hey, look at this nice proclamation from New York State. Why don't we do something? Why don't we have a lunch? You know, it's not going to be big to start out with, but one of those institutions I just mentioned, they do like a whole week of programming. They'll do poster days. They'll do some continuing education. They'll make it more specific to an NP rather than generic Nurses Week. So I encourage you to tell your institution to recognize NP Week. Anybody else? So here's the point. This is my Square reader. Credit card reader. So if you're interested, again, no pressure from me. Fill out your application with your demographic information, and I'd be happy to answer any other questions or swipe your credit card. Okay. Oh, thank you. Oh, you're welcome.